My name is Terry Olson. I am here to introduce your next speaker, but first I want to tell you a little of my story. My daughter Caitlin was 16 when she had her first grand mal seizure. She was diagnosed with epilepsy. Caitlin didn't let epilepsy slow her down. Once she ramped up on the meds, Caitlin got back to her studies, sports, and her busy social life. She graduated from Bothell High School in 2006 and continued her studies at the UW. She joined a sorority and lived on campus. Caitlin was having the time of her life. On November 1st, 2008, Caitlin, just 1 month shy of her 21st birthday and a junior at the U, died of SUDEP, sudden unexpected death in epilepsy. Her dad and I, here's Caitlin. Here she is. Her dad and I had never heard of epilepsy, or never heard of SUDEP. Caitlin's family and friends have done a lot of healing in the last 10 years. We joined the Epilepsy Walk in her honor in the spring of 2009 and have continued to support the Epilepsy Foundation at the walk and the auction and volunteering. Our next presenter is Dr. Franck Kalume. Dr. Kalume is a principal investigator in the Center for Integrative Brain Research at Seattle Children's Research Institute and an assistant professor in the departments of neurological surgery, pharmacology, and global health at the University of Washington. He received a PhD in neuroscience from the University of Tennessee Health Science Center. He completed his postdoctoral fellowship at the University of Washington under the mentorship of Professor William Catterall in the Department of Pharmacology. Dr. Kalume served as an acting instructor in the Department of Pharmacology at the University of Washington before joining the faculty of the Department of Neurological Surgery and the Center for Integrative Brain Research at Children's Research Center in 2012. His current research interests include understanding the cellular and molecular mechanisms underlying sleep disturbance and sudden unexpected death, and investigating the anti-seizure properties of the ketogenic diet in Dravet syndrome and other genetic epilepsies. Please welcome Dr. Kalume.
Good morning, everyone, and it is my pleasure to be the presenter for this topic today at the Epilepsy Foundation meeting this morning. And I would like to thank Terry for the nice and kind introduction, and also I would like to tell her that I feel her pain and talking about her daughter, about this very interesting but also very moving condition or complication of epilepsy, which is sudden unexpected death in epilepsy. So it's a very devastating consequence of epilepsy. We know that from all the presenters, even this morning, you heard about epilepsy, that epilepsy is usually present with other comorbidities or other neurological conditions together. And sometimes it's not only the seizures, but other complications such as sleep impairment and more that affect the quality of life of people suffering from it. And so today what I plan to do is just to go over an update of what we know about sudden unexpected death in epilepsy and also to present some of our work in animal model of treatment-resistant epilepsies and how it brought us to our understanding of this condition. I have no disclosure. And for the outline, I'll review the definition, the epidemiology, the mechanisms, and provide an insight into the mechanism of SUDEP based on our work on Dravet syndrome and focal cortical dysplasia. And from there, I'll go to the conclusion. And to start, I would like to mention that people with epilepsy have several causes that can lead to death. And these causes are listed here. They include motor vehicle accident, falls, drowning, suicide, drug poisoning, pneumonia as a complication from the seizures, or status epilepticus, which can be defined briefly as a continuous seizure that lasts for more than 5 minutes in its new definition. And such a seizure can precipitate death. And we also know, as I mentioned earlier, sudden unexpected death, or SUDEP, can also be the main cause of fatality among people with epilepsy. And it is known that this is the main cause of fatality in epilepsy. But what is sudden unexpected death in epilepsy? There is here I'll present what is known as the new and unifying definition of SUDEP. And it is called unifying because it's bring the element from two main definitions that were used in the field and presented by Anninger and Nashef both from Europe. And it was in the 2012 that this new definition has been adopted in the field. And here I'm not going to present the whole definition, but show you a summary of what the definition talk about. So it's mentioned that a case of death is called SUDEP when a person had one epilepsy and that death occurred suddenly. Death was unexpected because the person was in reasonable health, except that they had epilepsy. And death occurred during a normal activity. It was not an accident or injuries from other event. And the cause of death remain unknown even after autopsy. And then the sixth criteria is that death is not the result of status epilepticus or long prolonged seizure, as we know that those can lead to death, and it's a big medical emergency. And then from the definition, other clarification have been brought into the SUDEP field, where we have now a classification of this type of death. And mostly this classification is done for research purpose, where we can have what is called SUDEP plus, and this is in the case where there is a concomitant condition that may be identified, and that can be also contributing to the cause of death. And that's another type of SUDEP can be called probable SUDEP. And in this case is that we have all the conditions that we saw from the previous definition, but autopsy was not performed for some reason. Or we can have a possible SUDEP, and here is if there is a competing cause that can explain why the person passed away. Near SUDEP is in this case a case where the person was revived or resuscitated, and they were having a seizure or some event that showed that they were gonna go into cardiac arrest, or even the cardiac arrest and respiratory arrest have occurred. and then there was an intervention to stop the process going into SUDEP. Not a SUDEP when there is an alternative cause of death, and then classify when we don't have enough information to make a complete conclusion. From an historical perspective, this SUDEP has been known to afflict a lot of people in epilepsy for a long period of time. And here I can show you from the history of the United States in 1773. The President George Washington had a daughter named Patsy who passed away from SUDEP. And this is a picture of the daughter showing here. And across the water in England, we know that in early 1900s, Prince John Charles Francis, who was son of King George V of England, died from SUDEP. And here, this is a clip from a newspaper showing his picture here. But again, this was also a very sad story because the royal family kept their son in away in a farmhouse, away from the rest of the family, because they were afraid that people will know that they have a son with epilepsy. And this is very important because until today, there is always a stigma associated with people with epilepsy. And not only in England, but all the way around the world, in the United States and many parts of the world, this stigma still exists. And it is very important for us to inform the public and the communities about epilepsy so that these stigmas are not present anymore. And for those who are in the audience, the movie aficionados, you know that there is a movie named The King's Speech that earned the Best Picture in 2010. And this was a movie portraying a history of England. And here is King George VI, who was son of King George V, or also the brother of Prince John, who died of SUDEP. And here in this story, the movie was depicting him as he ascended to the throne and had some other impairments, speech impairment that he had to overcome during that time, because it was important for him to make very key important speeches in trying to rally the country, which was at the brink of war during that period of time. And here to the right is his friend from Australia, who was a speech therapist who was helping him through that endeavor. But what I would like to mention here is that despite the fact that we've known about SUDEP for many centuries, there is only limited information about SUDEP in the literature. And as you can see here in this study, only a few mention of SUDEP were done here before 1993. And as far as public awareness, there was almost no public awareness up to around this time. And it's only in 1995 that a big event happened. I call it big because this is when families, members who lost their loved ones through SUDEP decided to put together an organization, a charity organization that had the goal to raise the awareness among the public about SUDEP and also among the medical community. And after this, the organization had a conference in 1996. And it's only after that conference that you can see a tick into the number of publications, and this graph is showing the number of publications on SUDEP started increasing, and even more exponentially up to even today. And so this was a very big event, and it shows how family members and the public can drive the interest and drive the medical community to focus on a problem that is of important concern to them. And so studies of the epidemiology of SUDEP have shown that the incidence vary when you look into different groups of epilepsy, and looking at population base, or even looking into the clinic population of people with epilepsy. What has been found is that the people who have the highest incidence of SUDEP are those with refractory epilepsy, or this is the epilepsy that is medically difficult to treat, and or those with those awaiting surgery, as you've heard from previous speakers, that these are also some of the epilepsies that are difficult to treat with medication, and they have to go through surgery or VNS implantation procedure. And so this is the population that's highly at risk. And when you look at the incidence in function of age, and we see that the highest incidence of SUDEP is among people in their 20s to their 40s, as shown in this study, bringing together 3 population-based studies in a systematic fashion. A recent study that was done in Sweden has shown that SUDEP can even occur in a younger age. It's not only in people who are in their 20s and 30s. You can have SUDEP even in a younger population, as shown in that in the figure at the bottom. And then when you look at the onset of the epilepsy, and based on the onset of epilepsy, we see that the cumulative risk for SUDEP is higher in those who had epilepsy onset at a much younger age, as shown as in the red graph here. And throughout their whole life, you have the risk of sudden unexpected death is much higher than in people who had epilepsy onset at a later age. And recently, the American Academy of Neurology and the American Epilepsy Society puts together experts who went through a systematic review of the data on SUDEP. And what they come up with is that they show that the risk of SUDEP is rare in childhood. And it is estimated at about 1 death in 4,500 children with epilepsy. And in other words, it's very important to put this into perspective, that out of these 4,500 children with epilepsy, you have 4,499 children who are not affected by this condition. And then when you look among the adult, and SUDEP has a rate of 1 in 1,000 per year. And again, putting this into perspective, this is an uncommon event. You have about 999 people who do not suffer from SUDEP. So this is an important way to put all this into perspective, because this is a very serious condition, and it's often leave people with some anxiety when you hear about this information. But we know that people with epilepsy would like to know about SUDEP. They want to be informed, and they want to know about all the risk that can be of this condition occurring. And then, so very recently at UCLA, a group of investigators came up with a risk assessment list, and which they called the SUDEP-7. And through this, I'm not going to go in detail of all the items on the list. Through this, the key important thing to see is that from item number 1 to 5, all of these refer to the presence of generalized tonic-clonic seizures and how many of them occur in the person before you can estimate the risk for SUDEP. And then the next things that they look at is the number of anti-epileptic drug used. And we know even through the previous speakers that once you reach the 3 and more AEDs, this type of epilepsy is now being considered as a resistant epilepsy. And another important key element that they found is that the presence of developmental disability is very important as part of risk for SUDEP. The Center of Disease Control made its own revision of all the data available, and what they found, they kind of summarize it in a little bit less complex way than here, where they indicate that the main risk for SUDEP are uncontrolled frequent seizures and generalized tonic-clonic seizures, and these are the very complex convulsions involving tonic and clonic movement convulsions of the body. And so beside these main risk factors, there are also some possible other risk factors that can be identified, and these include seizures that begin at a younger age, and as I show you, that an epilepsy starting at a younger age has a higher risk of SUDEP. And another element that can be found here is that how many years the person has been living with epilepsy, which kind of associated with that, and also missing the doses of medicine or alcohol intake can be a risk factor for SUDEP. And all of the risk factors for SUDEPs can be modified, and we know from genetic studies and all the advances in genetics have led us to understand a lot of the genetics aspect of the epilepsy and even of SUDEP, that I'm not going to go into this very complex list of elements, but what I'm showing you, I want you to remember, is that there are some gene mutations that can affect the risk of SUDEP, and most of these genes are genes that are expressed in the brain and genes that are involved into the causes of epilepsy, and some other genes that we know that can can influence the risk of SUDEP are those that that can cause cardiac diseases, and even and the third group of genes is the group with genes that are involved into neurodevelopmental disorders. And so in order for us to understand SUDEP and even think about ways to start countering this condition, we have to understand the mechanism. And the source of evidence that we have up to now comes from studies in animal, and that's the majority of evidence that we have. And a small portion of evidence come from studies in human, and we can understand that studying animals have the advantage of helping us manipulate the animals and in a way that we cannot do in human. And we should also mention, I would like to also mention that studies in human are mostly focused on cases that are under epilepsy surgery evaluation, as shown in this picture, because it's very difficult to get people out in the community and try to study SUDEP. And we know that this is an event that occurs in most of the time unpredictably, and very difficult to identify when this can occur. And when you do these studies in epilepsy monitoring units, some of the disadvantage that you will have is that the patient will be under AED reduction or discontinuation, because you would like to see where the seizure is coming from, and even to see if there is a presence of seizure or not. And there is also, in this situation, for most of the studies that come from human, is that in most of the cases, the studies are done without evaluating respiration or blood pressure. But this is changing because people who are focusing on epilepsy, on SUDEP studies, start inquiring for these monitoring to be included in their records. And so what we know so far is that there are three mechanisms or a model that shows three paths of ways that you can get to SUDEP. And the key is that a person will have a seizure, and then this seizure will cause cardiac, respiratory, or brain dysfunctions, and these dysfunctions will lead to SUDEP. And we also know that the cardiac, respiratory, and brain dysfunction can interact among themselves in a way that one can aggravate the other, and leading and even precipitating this the path to SUDEP in a faster fashion. And when you look into more details into this, what you find is that as seizure occur and in the aftermath of seizure, before you get to death, there are multiple other things that can happen. And there are many factors that I summarize here. I'll go back here. And factors that may be from environmental factors, from the physical milieu, such as the presence or absence of supervision. If there is supervision in the early aftermath of the seizure, that can influence the path to death here. And is the person asleep or not? Because we know that in some cases, if there is the person is asleep and there is no one monitoring them, and there is no way to stop this course of event from occurring. And here we also know that there are some susceptible elements such as sleep deprivation and non-adherence to medicine that can precipitate seizures and lead to SUDEP in some cases. Another type of environmental factors can come from the genetic and biomedical, biochemical, I should say, milieu, where some neurochemicals that are expressed in the either in the brain or even at the cardiac level can influence the physiological events that occur before death. And in this case, when you look at cardiorespiratory dysfunction, there can be some effect of neurotransmitters such as GABA or glutamate that can precipitate death in one way. Or other neurochemicals are things like acetylcholine and more that can lead to SUDEP. Some anatomical changes as well can influence respiration and cardiac dysfunction. A landmark studies in human that have shown us that cardiac and respiratory dysfunction are implicated in SUDEP is a study conducted by Professor Rivlin of France, where they showed that in a population of patients who were being monitored for epilepsy, they saw that SUDEP occur immediately after they had a seizure, and that the seizure led to cardiac, and here shown suppression of cardiac and respiratory function. And this suppression of cardiac and respiratory function can occur in different patterns. As you can see, this is one patient where it's a brisk suppression. In some cases, there is some changes. And when they map it on a time map like here, you see that different colors here shows different type of respiratory abnormalities that can occur or cardiac abnormalities that can occur before death. And this is in a limited number of patients that I show here. But there are more patients that can have these abnormalities, and they had about 9 of them into their studies. And other studies have shown that post-ictal generalized EEG suppression, and this is the suppression of brain activity after a seizure, are very important in the mechanism of SUDEP, and as well as in the mechanism of SUDEP. And what the studies have shown is that this type of brain activity suppression occur greatly in the case of generalized tonic-clonic seizures, more so than when somebody has a focal seizure. And it is believed that this type of impairment of consciousness the path or can reduce the cardiac and respiratory reflexes and lead toward SUDEP. In other cases, we have sleep or the seizures that occur during sleep, leading to some suppression of cardiac and respiratory dysfunction. It's happened that when the seizure occurs during sleep, these type of cardiac and respiratory depression are even more severe. And this may be a condition where SUDEP can occur more readily than when the person is awake. And so in my lab, we studied SUDEP and looking at Dravet syndrome. And Dravet syndrome is a very severe type of epilepsy, and you've heard this morning about this condition. And it comes with the high risk of SUDEP. And what are the mechanisms? And we wanted to understand, to use this an animal model of Dravet syndrome to understand the mechanism of SUDEP, but also to look at some other animal model to see whether we can understand whether these mechanisms are the same when you go from one epilepsy to another. But speaking about Dravet syndrome, we know that this condition begins in the first year of life in most of the patients, and most of the time it starts with febrile or terminal seizures. And these seizures can evolve into even more complex seizures. And then people with Dravet also develop several concomitant conditions that can be difficulty of moving, ataxia or spasticity, cognitive impairment, sleep and circadian rhythm disturbances, premature death, which is sudden unexpected death, and the topic of the talk today. And also most of the seizures are very difficult to treat with anti-epileptic drugs. Genetic studies conducted beginning with some studies in Belgium in the early 2000s have shown that this epilepsy is due to genetic mutation in a gene known as SCN1A. And this gene is the one that encodes the sodium channel NAV1.1. And a review of all the studies of SUDEP in Dravet syndrome has shown that SUDEP is again the main cause of death in this epilepsy compared to all the other type of causes of death, such as status epilepticus, accident and drowning, infection, and more. And when we look at the distribution of SUDEP across the ages, again here you can see that in Dravet, most of the SUDEP occur in the younger patients, somewhere between 0 and 10 years of age. And so this indicates that the SUDEP occur in Dravet much earlier than in the general population, epilepsy population, where we see a SUDEP rate peaking in this age between 30 and 40 years of age. And the rate of mortality in Dravet, when we look at all the causes of death, it is estimated to be about 15%. And but those deaths are directly associated with SUDEP are only 9.3%. And even though they are lower than this, we should mention that this is the highest rate of SUDEP seen in epilepsy field, and it's about twice the rate that we see in adult population with epilepsy. So in our study, we did a genetic experiment where we deleted a portion of the sodium channel gene, as shown here by the highlighted segment of the gene drawing. And when we deleted that segment of the gene into mice, and what we found is that we found that these mice develop Dravet syndrome, and they can then be used as our nice model of Dravet syndrome. And they have seizures, as shown in this picture here. They have generalized seizures and many other seizures that I'm not presenting. And like Dravet patients, they will have ataxia, cognitive impairment, and all the other comorbid conditions that are associated with the seizures in Dravet. And they also develop SUDEP. And to study them, we can do these EEG on a small brain of our mice. And we can also do ECG recordings. And from these recordings, then we can evaluate when these mice have a seizure and look at what's happened to their cardiac function. And what we usually see in this case is that when they have a seizure, we see that there is an increase into their heart rate. But suddenly, around the end of the seizure, we see there is a drop in cardiac, in the heart rate. And this is what is unusual, because as you know that when a person is having this convulsive movement, you expect the heart rate to go up. But here we see that at the end, something goes wrong during the seizure that destabilizes the normal function of the heart. And in this case, fortunately, the animal recover. And but in some other cases, as you could see here, when the animal go through SUDEP, we see that they never recover from this bradycardia, severe bradycardia. And so this indicates to us that during a seizure, this type of event can occur even in human and precipitate SUDEP. And so instability in cardiac function is an important factors leading to SUDEP, as we identify in our studies. And it's not only that the rate of the heart goes down, but also even the electrical impulse as it's traveled throughout the heart is distorted. The normal heart cardiac signal look like this, but during the seizure you can see that it's become very distorted in our model of Dravet, and we think that this distortion of the electrical impulses traveling throughout the heart is also a factor leading to SUDEP. And the mechanism, the model mechanism that we have is that SUDEP in Dravet occur when a seizure starts in the forebrain and travel down into a region of the brain here in the brainstem where we have the control center. That's the center that control the cardio-regulatory control center, which control the heart function. That is disturbed, and then we have this suppression of heart rate, and we think that's what lead to SUDEP, or one of the events leading to SUDEP. And to continue our studies, then we thought then in this brain region we also have another control center, and this is the control center for respiration. And we think that if the seizure travel to this region, it may also affect the control center for respiration, and that can be also an additional contribution to the mechanism of SUDEP. To study that, we can record EEG, ECG, and respiration from our mice using this device, a plethysmography, and these are studies that we did with the Ramirez lab at the Seattle Children's Research Institute. And with this, we can look at the time when the animal have a seizure and monitor their cardiac and respiratory rate. And what we see that immediately after the seizure, there is a suppression of both cardiac and respiratory function. And this tells us that it's not only that the heart is affected by the seizure, respiration is also affected by the seizure. And combining these two things can lead to SUDEP. And so this I presented evidence in our model of Dravet. And then the next question we ask was, is this type of event or this type of abnormalities occurring in another type of epilepsy? Do they share similar mechanism of SUDEP? And to study that, we have a second model, a model of focal-cortical dysplasia, which is known as a group of malformation of the brain. And these are diseases that manifest by themselves by an abnormal formation of the cortex or other brain regions. And it is known to lead to epilepsy, and especially in the young and young adult, in children and the young adult. And recent studies have shown that this epilepsy is associated to a gene known as PIK3CA. And this gene is part of a long network of a signaling molecule in the cell. And this signaling molecule is very well known to be involved in the normal development of tissue in our body. And also it has been implicated, this function has been implicated in cancer. And so Dr. Dobbin found that association between mutation in that gene and a group of these brain abnormality diseases that he showed that in some cases where we have only a small part of the brain or a mosaic mutation affecting only a small group of cells, we can have a disease that is only manifested with a small region of the brain that look abnormal, as shown here at the pointing area on the MRI picture. Or we can have part of the brain, almost half of the hemisphere that is affected and look malformed, or it can be a general malformation that affect the whole brain. And this is the condition that is known as focal-cortical dysplasia. This one is known as hemimegalencephaly, and this one is megalencephaly. And we were able to model this in animal, where we can generate, by gene mutation, we can generate a mouse with a big brain like in megalencephaly, or just normal brain with some cells that are malformed. And so using this model, we can look at the model and see, do they have epilepsy? Yes, they can have seizures, as shown here in our recording from them. And then we look at whether they have abnormal cardiac and respiratory function during their seizure. And the answer is yes. And this type of abnormality, they look as what I show you for Dravet syndrome. And this evidence shows us that there may be a shared mechanism of SUDEP in multiple epilepsy syndrome. And from these findings, we then propose that there may be some of the new method of preventing seizures can be used to prevent SUDEP, and not only preventing the seizures, but here actually I should say these are methods that are used for neuro or cardiac stimulation therapy. And so we hope that maybe using a pacemaker can help the patient during the seizure to avoid going into the bradycardia or the distortion of their cardiac function. Another way we are thinking of this is that maybe using the vagus nerve stimulation approach, but here to modify it, because in this case, what we would like to do is that we would like to suppress the vagus nerve, because its stimulation can cause suppression of the heart. But what we want to do is that during the seizure, to prevent that abnormal suppression of cardiac function, to help the patient survive what would be otherwise a fatal seizure. Another approach that we think can be used in these cases can be trying to stimulate the diaphragm or the phrenic nerves where the control of respiration run through, and in this case, helping the patients going through those abnormal, preventing those abnormal respiratory function during a seizure. And other methods are just a normal CPR as a way to prevent. But we know that in the field there are many other type of methods that are coming up, and there are emerging technologies that involve suppression of the seizures themselves, or there may be just a method that will alarm the person next to the person having a seizure, to be able to go back and resuscitate them if they are well trained. Or there are also some other methods such as mobile devices from your phone and also smart watches that can alert people when they're having a seizure, which may otherwise be fatal. And so in conclusion, today, after 2 decades of studies or increased interest in the research of SUDEP, we know that through the epidemiological studies that SUDEP risk is rare in children, and its rate is about 1 in 4,500 person will have a SUDEP per year. And among adults, this risk is small. It's about 1 in 1,000 people. And the risk can be a little bit higher in people with refractory epilepsy. And the presence, some of the risk, the major risk factors include the presence of the presence and the frequency of generalized tonic-clonic seizures. And as far as the mechanism, what is known so far is that the seizure-induced brain, cardiac, and respiratory dysfunctions are the main causes of SUDEP. And for prevention, the most effective one will be to suppress the seizures themselves, because we know that SUDEP is a seizure-induced event. And then if we can prevent the seizures from occurring, we hope this will help. And there are many other challenges that remain into the field, and some of them are listed here as on this slide. Is that how do we identify the specific individual who is at risk, and how do we identify even the time of the day or the time, or even be able to predict at what time the person is at high risk. And can we also identify among the seizures which one of the seizures will be fatal? All of these are not very clear to us at this point in this field. And then we hope that we can test all these emerging new technologies that are coming, and these technologies, some of them help us identify the seizures as it's come and prevent it from going into a catastrophic event. And I would like to thank you all for listening, and also I would like to thank my lab here in the picture, and especially Michelle and Nikhil, who are the post-bac students who did most of the studies that I presented here this morning, and my collaborators at University of Washington, as well as at Seattle Children's, and without forgetting all the funding agencies that give us the money to conduct our research. And from here, I'll take questions.
Thank you. I have a question that probably sounds simple, but I suspect the answer is complex. Mm-hmm. Just as a layperson, when I hear the name SUDEP, I'm confused about what sudden means, and I'm confused about it in terms of saving people. When you say sudden, does this mean that somebody has a seizure and they're dead within 30 seconds? And obviously, the complex part is how much of it is heart, how much of it is cardiac, how much of it, is respiratory. But if you have a family member who has seizures and you fear that they may have SUDEP, if they have a seizure, are they going to die right away? Are you going to have time to call 911? Should you be thinking about doing CPR? What does sudden mean?
Yes, and I should make a full disclosure that I am not a clinician, so I cannot advise you on a clinical aspect of this. But on the research aspect, I can say something, and then you can have a conversation with the clinicians in the room afterwards. But what sudden means is it means that it's something unpredictable. And in most of the cases here is that, as I mentioned, is that the event will occur when the person is asleep, and in most of the time you don't even have time to intervene. And so that's why what we are advocating here is that having somebody or having a monitoring device that will alert people around you to let you know that the person is you're having a seizure, or and then bring the help that you need to get to you.
You have the time though. If you have a monitoring device,
yeah.
Does that buy you time, or do you have the seizure and then boom, 30 seconds or a minute later you're dead?
Yeah, so there are cases where the SUDEP will occur very quickly, and there are some reports of a little bit of a delay time, and Dr. Novotny can attest to that. And in our animal model, I can tell you that this can occur in less than 30 seconds. Yeah.
So you mentioned refractory types of
Yes.
epilepsy have a higher risk, and trying more than one medication kind of leads you to becoming refractory. Is there a risk related to taking more than one medication at a time? Has that been found in research, that being on multiple medications affects your risk factor?
There have been studies looking at very specific medications and see if some specific medication increase the risk of SUDEP, and I think one of it in the Dravet was lamotrigine. But it's depend on what medication you are taking, and again, this is another type of question that the clinicians will be more the person to ask. Yeah.
Thank you. I was wondering, the cardiorespiratory refractory period that you're seeing with the decreased heart rate and respiration rate, is that just post generalized tonic-clonic, or do you see that after other seizure types?
In our study of Dravet, we see that those occur during the generalized tonic-clonic seizure, and I did not go in detail, and only they are initiated during the tonic phase of the seizure. But most likely they occur in generalized tonic-clonic seizure. One of the reasons is maybe that the generalized tonic-clonic seizure involve most of the brain and even the control center for those functions.
Thank you.
So what are your studies showing regarding the effectiveness of CPR in cases of SUDEP?
The effectiveness of CPR will depend on, I don't think there is a good study that look at it, but it also depends on how quickly you identify the situation and how quickly you intervene. All right, thank you. Thank you.